Metabolic load, structural recovery, and post-stroke decoupling of heart and kidney, number 1543, PPT 96, February 21, 2026, Gerald C. EclaireMD Foundation, category CVD, CKD and Metabolic Systems. Preface: the findings described in this report come from my long-term experience with 3 different diseases affecting 3 major organs, heart incidents related to cardiovascular disease, chronic kidney disease, and a hemorrhagic stroke in the brain. These observations are rarely discussed in routine clinical settings, not because they are unimportant, but because they cannot be recognized from isolated laboratory measurements. Most clinical judgments are based on whether a single biomarker is above or below a target threshold at one point in time, which is similar to looking at snapshots. In contrast, this 17-year longitudinal record behaves like a movie that shows the dynamic trajectory of the human body under sustained metabolic load reduction and lifestyle modification. Only through this continuous time sequence can we see system behaviors such as different organ response speeds, long-term structural recovery, metabolic memory, and the post-stroke decoupling between body weight and glucose. These time-dependent patterns are not visible when health is evaluated only by threshold values. Introduction: this report is not based on a cross-sectional cohort, a short clinical trial, or a statistical correlation. It is a continuous 17-year longitudinal record inside one body, where all major metabolic inputs were tracked and outputs were progressively modified. The output variables are 2 integrated risk estimates for cardiovascular disease CVD and chronic kidney disease CKD, both derived from a combined assessment of body weight, glucose, blood pressure, lipids, diet, exercise, sleep, stress, and hydration. Because these risks represent the total metabolic state rather than a single biomarker, their trajectories reflect the system behavior of the human body under long-term load reduction. Several observations emerging from this dataset are not easily recognized in traditional clinical practice, which is largely based on isolated laboratory values and episodic visits. My 5 CVD events occurred between 1994 and 2004, during the period of severe obesity and uncontrolled diabetes, even under medications including metformin, my severe CKD condition, under the doctor's recommendation for dialysis, was identified in 2010 after approximately 2 decades of chronic hyperglycemia since 1990. The hemorrhagic stroke in mid-2025 followed a different failure mechanism: long-term structural weakening of cerebral small vessels through calcification due to 36 years of diabetes, followed by an acute triggering load from severe hypertension on June 21, 2025. This life trajectory provides a natural experiment showing how one upstream disease, diabetes driven by obesity and metabolic overload, can produce 3 different organ failures through 3 different mechanical pathways. After 2010, I initiated a comprehensive lifestyle redesign without taking any medications, including vitamins. Over the next 16 years, body weight fell from a BMI of 31 to below 24. And EG dropped from extremely high levels of over 300 mg of DLHbA1c at 13% to near normal values of around 110 mg of DLHbA1c around D6% without any diabetes medications. During the same period, both CVD and CKD risks declined continuously. As a matter of fact, during the period from 2014 through 2026, I have not experienced any CVD or CKD events. Key system-level findings: 2-phase structural recovery. The risk reduction did not occur at a constant rate. Between 2010 and 2014, there was a rapid drop in CKD risk and a significant decline in CVD risk. This corresponds to the period of the largest reductions in both glucose level and body weight. After 2015, the rate of improvement slowed, and the curves entered a long stabilization phase. This behavior is consistent with a viscoplastic dynamic system. When a large external load is removed, recovery is fast at the beginning because the strain rate, the speed at which damage changes over time, is high. A high strain rate, when combined with strong influential factors, amplifies the input stress and raises the strain-stress energy level, which leads to greater damage in the human body. Once the system moves into a lower energy state, the rate of change slows down. From that point on, improvement becomes gradual and more stable, and the system becomes less affected by short-term fluctuations. Traditional clinical observation rarely captures this 2-phase recovery because most datasets are too short in duration. Organ-specific sensitivity. CKD risk responded earlier and more steeply to metabolic improvement, indicating a higher sensitivity to glucose toxicity. CVD risk declined more gradually and continued to improve in later years when body weight was still decreasing but glucose had largely stabilized. By the way, in my case, the rate of glucose reduction was faster than the rate of weight reduction, which suggests that body weight carries a higher metabolic inertia than blood glucose. This suggests that different organs are mainly affected by different factors. For the kidney, the most important factor is glucose. When my glucose dropped quickly after 2010, my CKD risk also dropped quickly. This tells us that good glucose control is the key for protecting the kidney, especially in the early stage of recovery. For heart incidents, the situation is different. Their improvement depends on both body weight and glucose, together with blood pressure. In my case, even after my glucose became stable, my risk of heart incidents continued to fall because my body weight was still going down. This means that excess body weight is a long-term physical load on the heart and blood vessels, and reducing that load keeps lowering the chance of future heart problems. In simple terms, glucose control helps the kidney the most and works quickly, while weight and glucose reduction plus blood pressure control provide continuous long-term protection against heart inside. NDS. For some patients who have suffered from artery blockage and required stents, it is helpful to explain this in simple terms. A stent is a small metal mesh tube that doctors place inside a narrowed coronary artery to reopen the blood flow. In most cases, the heart muscle itself is not weak. The real problem is that the blood supply pipes become narrowed by plaque, so the heart cannot receive enough oxygen. The stent works like a tiny internal support that pushes the blockage aside and keeps the artery open so blood can flow normally again. This is a flow problem, which is different from my stroke that resulted from the rupture of a fragile small vessel in my brain. These are two different vascular conditions, but both are related to long-term changes in the arterial system. My 5 CVD events were expressed as chest pain, which most likely came from temporary insufficient blood flow to the heart muscle. During that period I had severe work stress from my CEO job and legal actions, obesity, and uncontrolled type 2 diabetes. These combined factors increased my heart's oxygen demand while narrowing the coronary arteries through plaque buildup. When the blood supply could not meet the higher demand, chest pain occurred. After I reduced my body weight, controlled my glucose, and changed my lifestyle by selling my business, these episodes disappeared, which indicates that the problem was flow limitation rather than a weak heart muscle. Observations in clinical environments. This separation of organ response between heart and kidney is difficult to detect in conventional clinical settings but becomes clear in a long-term integrated data asset. Metabolic memory in quantitative form. In 2026, my EG rose due to the physiological or metabolic disturbance following my stroke in mid-2025. However, both my CVD and CKD risks continued to decline. This shows that short-term worsening of a single biomarker does not immediately rebuild long-term structural damage. The system retained the benefit of 16 years of metabolic unloading. This is a direct, quantitative demonstration of metabolic memory in a single subject over T. Post-stroke decoupling of weight and glucose. From 2010 to 2024, my body weight and glucose moved together, both reflecting lifestyle-driven load reduction. After the stroke in 2025, a new pattern appeared. My BMI continued to fall, while my EG rose. This decoupling is highly significant. It shows that the glucose increase was not caused by a deterioration of lifestyle. Instead, it resulted from internal physiological changes after the stroke, including stress hormone activation, sleep disturbance, reduced daily walking, and the body using extra energy to repair the injured brain. These conditions temporarily worsened glucose control even though my body weight and lifestyle continued to improve. My body weight continued to decrease, which means the physical load on my system was still being reduced. However, my glucose control became less stable after the stroke, with my daily average glucose increasing by about 10%. I actually slept more, about a 30% increase, and kept my diet about the same, but my daily walking decreased by about 50%. At the same time, my body needed extra energy to repair the injured brain. This recovery demand, together with reduced daily exercise, raised my glucose even though my lifestyle discipline did not change very much. Most clinical interpretations would attribute rising glucose to poor compliance. This dataset demonstrates that such a conclusion can be incorrect in the presence of a major organ event such as a stroke. A Continuous risk reduction despite biomarker fluctuation, even with the post-stroke glucose increase. Both CVD and CKD risks continued to decline because the total metabolic environment remained in a low W load state. This confirms that integrated metabolic condition, not a single laboratory value, determines long-term organ risk. Crossing a structural phase boundary, around 2020, both risks fell below approximately 0.50 and never returned above that level. This represents a transition from a high-risk state to a low-risk state. After this transition, the system became resilient to short-term fluctuations. Such phase behavior change is not described in traditional clinical language but is common in time-dependent biomedical material systems. Not erasure of past damage. Although the risks declined markedly, they did not fall to zero. This confirms the central principle: past structural damage cannot be totally erased. But future load determines survival. Clinical implications. These findings challenge several common clinical assumptions that temporary rise in glucose does not necessarily indicate lifestyle failure. Risk reduction can continue even when a single biomarker worsens. Different organs respond to metabolic improvement at different speeds. Long-term integrated metabolic control produces structural benefits that persist through acute illness. Most important, organ survival depends on the total metabolic load over time, not on whether a single lab number is above or below a target on one test day. A structural interpretation of 3 disease obesity increased my metabolic load and led to diabetes. And the long period of uncontrolled diabetes gradually produced systemic vascular damage throughout the body. My heart incidents occurred earlier, during the years when severe metabolic disorder was combined with heavy business stress, which increased both the oxygen demand of the heart and the narrowing of the coronary arteries. Chronic kidney disease appeared later as the result of long-term exposure of the kidney's small blood vessels to high glucose. The stroke followed a different pathway. Decades of diabetes weakened the material of the cerebral small vessels through calcification, and the final event was triggered by an acute rise in blood pressure at 175 mmHg that caused rupture on June 21, 2025. These 3 conditions, heart, kidney, and brain, therefore represent 3 different failure modes of the same vascular system operating under different types of long-term loading. Conclusion. This 16-year longitudinal dataset demonstrates that sustained reduction of total metabolic load leads to continuous multi-organ risk reduction through a time-dependent structural recovery process. It also reveals a post-stroke decoupling between body weight and glucose level that cannot be explained by lifestyle behavior alone. The key message is simple but rarely visualized. 1. The body behaves as an integrated system. 2. Risk is the output of total metabolic state. 3. Long-term load reduction creates durable structural benefit, even after a major event such as a stroke. A system that has already transitioned into a low-energy state continues to move toward lower risk. The kidney responds to chemistry. The heart responds to both chemistry and physics. We must treat the body not as a calculator of calories, but as a structure under stress. While a single lab test is a snapshot of the weather, a 17-year longitudinal study is a map of the climate. The decoupling of glucose and weight post-stroke proves that the body prioritizes internal repair over external markers during a crisis. Disclaimer: I write this paper not for fame, but to share what I have learned so others can understand their health, prevent disease, and live longer, healthier lives. This content is provided for educational reference only and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights for this article and its related materials belong to the author, Gerald C. This content is provided for educational reference only and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights for this article and its related materials belong to the author, Gerald C.